Okay, can you guys see my screen? Okay. So this is session 9, Introduction to Outreach. That's what we are doing. And again, the outreach is very more than 90% or so, or at least 90% of it definitely will be online and virtual. But a lot, this is introduction to outreach, but I'm talking about our outreach. So keep that in mind, guys. Again, Dr. Johnson, thank you again. Thank you very much for bringing us the beautiful materials. And I saw the slides today. It's just beautiful. Thank you.
You're welcome.
And I'm going to ask Brother Abdurrahman if he can recite the prayer. Was Abdurrahman on this?
Welcome, everyone. Yeah, I'm on. So I'll just recite a real quick dua. بسم الله الرحمن الرحيم ربنا آتنا من لدنك رحمة وهيئ لنا من أمرنا رشدا. And the translation goes, Our Lord, bestow upon us mercy from yourself and facilitate for us our affair in the right way. Ameen. May Allah accept.
Ameen. Mainly reciprocal relationships. How do we strengthen the relationships? And there is a lot of stuff just in those 2 words. It is extremely heavy, and a little bit of project management along with it. So with that, I'm going to let Dr. Rebecca take the lead. Thank you again.
Okay. So sort of happy, where are we? Wednesday. Yes, Wednesday. Yes, happy Wednesday. So today the core competencies we're going to focus on are, if we can have the next slide, Fatima. So we're going to think again, continue to think about building your ability to identify issues, strengths and resources, and connections and coalitions, and the ability to conduct community organizing to some extent in terms of reaching out and sort of setting up in relationships. And we're carrying on identifying resources and access to resources. And I want to introduce to you today the Chicago Health Atlas. So I'll give you an example of the resources which are mapped by the city in this case. I'm not sure we'll have time to do the state as well, but we'll have the resources that are mapped by the city. But there's lots of things missing. And I wanted to show you this because I think when we're doing more of the asset mapping on Saturday, I want you to think about what's missing and how we capture what's there. Because what was interesting is I was typing the names of mosques in and putting in zip codes, and sometimes they came up, but sometimes they didn't. And then, for example, the Islamic Community Centre didn't appear. So and yes, it appeared on my Google map, but it didn't appear in the database. So that's interesting. And so it's interesting when things appear and when they don't. And some of the times that mosques did appear was when they offered care and or food banks. So you'll see when I show you that database that you'll see the assets.
That's interesting.
You'll see the assets that the city maps. Yeah. So I wanted to show you that, and also get a sense from you about the sort of the number of zip codes that you're wanting to look at. I know, so we need to think about how wide to go, but you can see how you can do that. I'll show you how you can use that map. Yes, so, and that will help us all to participate in individual and community assessment, because what I want you to be able to do is I want you to be able to do your own community asset mapping, because I'm going to share the 10 conditions or the 10 issues that came out of the project that preceded our project, which was the eMarch project. And very helpfully, the discussions that took place during that project identified 10 issues. So we're going to have a look at those issues. And then we're going to sort of also keep in mind that worry-free organisation is about access to care. And we're going to think about assets which enable you to talk to mosques about access to care needs, but also perhaps we'll think about these other 10 health conditions and factors. It's a combination of those things, these issues, which the community have identified as being things that are of concern. And I'd like to ask you if they're still of concern. Okay, so we're beginning to set our goals as well. So this is session 9, introduction to outreach for research engagement, and then in session 10, I'll give you the range of asset mapping options and tools that there are. But first of all, yeah, there's an icebreaker. And so I love this picture, which my mum sent me, which is actually in London, and it was about how a school in London have been giving their kids hula hoops in order to practice social distancing. So in order for kids to they understand social distancing. So I just wanted, as an icebreaker, just a few of you to share things that you've observed in your communities which help you educate about social distancing. That's my contribution.
Good one. What do we do?
I mean, what's happened in mosques themselves? Has that been an issue?
Oh yeah. Yes, so I'm sure other people can share this too, but in mosques, you know how they pray, and this is very interesting, Dr. Rebecca, at least for us, it's a norm, so we don't even think about it. But for you, I think it would be interesting to know. So when you stand during prayers, you're supposed to shoulders. That's how you're supposed to stand. So there is no, there is not a distance in between. So the whole idea is that you are one community. So there's there's a huge sense of community and belongingness when we observe the prayers in the mosques. But because of the social distancing, and in fact, even in the Mecca, for the pilgrimage, they actually had they stood people 6 feet apart. So there is one person would be standing, and the next person would be standing after the 4 prayer rugs. So they would have these distances where they would cross off on the mosque carpet that nobody can stand, and this is the one that you can stand in. So that's what they did in the mosques. Yeah, in addition to and they ask people to bring their own prayer carpet too.
Okay.
But in addition to my masks, that's what they did. Yeah.
Yeah, that makes a lot of sense. Does anyone else want to share an example? Or...
I personally like social distancing, very honestly.
No, it's not fun. It's not fun.
Okay, social distancing, yeah, I can't.
I did like this example. But what the reason I want to really encourage you is, one of the things I think that's really important with community asset mapping is observing. And I think I know that you're all listeners from what we talked about in earlier sessions, but I want you to be all observers as well. And I think just looking out for the way in which people adjust and and sort of their behaviours is very informative. It helps a lot. Okay, so we keep going. We're going on to the next slide. Okay, so just a knowledge check then. So yesterday we talked about 2 methodology standards which applied to the pre-planning phase of research engagement. The standard for formulating research questions and the standard for patient-centeredness. Now I'm just going to select from these, and I'm going to ask you which standard are the following. I'm going to ask you which about an activity, and then ask you to tell me which standard does it belong to. So identifying gaps in evidence, is that A, part of the standard for formulating research questions, or B, part of the standard for patient-centeredness, do you think? Yeah, good. They all seem to be coming through. Very good, very good. You see, you were listening. that's very good. Excellent. Oh, that's super. So yeah, and so what about? Okay, so that's a nice one. So what about engaging people representing the population of interest and other relevant stakeholders in ways that are appropriate and necessary in a given research context. Is that A, the standard for formulating research questions, or B, the standard for patient-centeredness? Yes, I know. It's funny when you take them out of their little boxes. It's not quite as easy to put them back in those, is it? Which is a good point. So yeah, it is actually one of the standards for patient-centeredness. So it's B, but engagement really should happen, as we know, before it all starts. So it was good of you to ask, good of you to think about that as it possibly being A or B, and I'm glad you're thinking like that, because you can't really formulate the question until you've engaged people about the of the people who are and identified what's interesting. So it's chicken and egg. It's often a chicken and egg situation. So that's one of the reasons I wanted to sort of highlight this. Okay, so one more. What about identifying, select, recruit, and retain study participants representative of the spectrum of population of interest, and ensure that data are collected thoroughly and systematically from all study participants? Do you think that's a standard for formulating the research question, or a standard for patient-centeredness? Oh, that's interesting. Okay, you guys, so you found that easier to answer that question. Although, yeah, but you are also, again, it is actually about patient-centeredness, because it's about the methodology of patient-centeredness, and trying to sort of get the right people to understand the population and also the data that's collected. But it should also be part of the standards for formulating research questions. So there's no, these checklists are supposed to help, but you've put your finger on an issue with this, which is that sometimes, yes, the checkboxes in one category actually are equally appropriate for another category. So, and what you're also telling me is that you also really believe that if you're going to do a research question which is patient-centered, you need to observe the standards for patient-centeredness, which is quite right. Okay, so if we go to the next slide. So today, so I want you to think about, we're going to think about identifying the gaps in evidence for a prevalent condition or a known health disparity. So we're going to carry on sort of looking at assets, and I'm going to help you map out that so that you can begin to see where prevalent conditions and health disparities. When I say a known health disparities, I'm using known in the sort of the way that Dr. Padella defined that. So it's a sort of, known at the city level, or it's a data known health disparity, not the unknown, which obviously you have a much better, you have a good lived understanding of. So we're looking for the known disparities, how they're mapped out. And then with standard 2, we're looking at engaging people representing the population of interest and other stakeholders in ways that are appropriate and necessary in a given research context. So we're thinking about how we engage the people that we want to work with, and that's reciprocal relations. So we'll have I'll introduce you some tools for reciprocal relationships building. Okay, have next slide. Okay, and so this session is about tools to facilitate quality engagement, and we're in the middle. We're definitely in the middle. Okay, next slide. But before we do that, I want to sort of remind us all that we're all assets. We're all, all of us around the table are assets. And Wasan's really kindly offered to talk about herself and her experience of community engagement in Jordan. So that would be awesome. So as you listen, please think about the way she's talking and the resources she's drawing on, because those are all assets.
do you want to share your screen, because I don't have the pictures embedded in that, so I can stop presenting and you can share your screen. Would you like to do that? Looks like Wasan is having problems dialing in or something. She was right here. Okay. Just texted her. Yeah, I don't know. I think she should be there. Oh, can't, she said can't join. She must be, what happened? Oh, she's telling me something. She texted me. I mean, we spoke 5 minutes before the meeting. Need someone to let me in. Oh, need someone to let you in. We don't see you here. Let me call her. I don't see anybody.
Yeah, no problem.
Assalamu alaikum, Wasan. Wasan, I don't see you here. I don't have. Can you would you like to join again?
Yeah, but it's not. No one is allowing me to join. That's the problem.
But we don't see you here either.
I'm gonna try again.
Oh, please. Yeah. Please try again.
Just a second.
Sure. I don't know what happened. We don't see her here, and then she's telling us that she's unable to join.
It looks like she's having a bit of trouble. So
yeah, it looks like it. So you want to move forward?
Sure. Yes, we can come back to.
Okay.
Yeah, hopefully she'll be able to join us. Yeah.
Okay. Sure.
Okay. We'll yeah. So yeah, we're sort of in the planning phase, and we're thinking about pre-engagement. And oh, she's here. Okay, that's brilliant. Right,
I'm sorry. I'm really sorry about what happened.
That's okay.
Don't worry.
I can start presenting, Wasan.
You again? I didn't hear you. What?
Oh, I'm saying that I can stop presenting and you can start presenting your slides.
Sure. Okay. It's not slides. It's only pictures. So.
Oh, okay. So you can talk and then you can share the pictures. You mean?
Yeah.
Do that?
Okay.
Sure. Go ahead.
You're presenting. How can I stop you from presenting?
I'm just stopping. Okay. Here I am. It's all yours.
Okay. I'm sorry. I'm really sorry.
No, that's fine. Happens.
I think it's there, right?
Mm-hmm.
It is, yes. Oh, wonderful. Yes.
Oh, okay, let's start. So, salam everyone. Bismillah. Before you start, I want you just allow me to ask you to take a moment and think. How many of us have known someone who is raising a child with Down syndrome? Or how many of us have met a child with Down syndrome? Surprisingly, Down syndrome is not that rare. Actually, it's common as 1 in 700 born lives in the US. and how to raise or deal with a child born with Down syndrome is not a thing you get to learn from medical school, especially if you were living in a third world country. Fortunately, we had an assignment at our qualitative research class to interview parents who raised a child with Down syndrome. So, do you remember when Dr. Rebecca asked us once about the open and closed questions? I don't know if you guys recall that. Well, guess what? We had to use those questions in the interview. But what really mattered, can you hear me, everyone?
Yes, we are listening.
But what really mattered were the results. We found, as most of the articles and literature revealed, that although having a child with Down syndrome can be a source of stress and anxiety, the majority of parents revealed that their personalities have grown positively as they started appreciating what really matters in life. Yeah, that was a surprise. As we are learning from the impart training, life is not only about making a research, but it's about doing one for a purposeful reason. That's when we said someone got to do something about it. As we all know, the need of engaging with the community is most wanted at underserved areas. We looked for a non-profit organization that aims to improve the lives of children with Down syndrome, along with a professional special needs specialist, a specialized pediatrician, the one you see on the picture, and a representative from the Higher Council of Special Needs in the country. Each one of them had the chance to educate the parents, counsel them free of charges, and answer the questions they had. It would have meant nothing if we asked the parents not to bring their kids, right? So our team had 2 joyful volunteers. I have their picture here. It's not working. Oh, okay. Yeah. Who played with the kids the whole time. And the children had the chance to use the microphone and perform their talents too. The best part was how we finally realized how that extra chromosome gave extra love. Kids with Down syndrome are the best in showing care, empathy, and love. We wanted the world to see how sweet these kids are. That's why we created an educational video about them. I can share that video with you on the chat if you want. Shall I send it now or at the end?
How long is it?
No. You can watch it later. It's 3 minutes, I think.
Oh,
3
okay.
minutes then.
And Dr. Rebecca would have to say to that, whatever she wants to do.
Okay. I prefer sending it and watching it later, if that's okay.
Yeah, if you sent it at the end, that would be lovely. Thank you.
Despite our work with those kids, our aim was not exclusive to this subject. We did videos and events about children with autism, cancer, and diabetes type 1, along with many other common chronic diseases. So the real question is, how can we apply our previous expertise to the American Muslim community in Illinois? I know you're all wondering about that. Well, I have been talking to Ms. Fatima about the need of having an initiative that can offer special needs to the Muslim children with Down syndrome, to let them meet, let their parents share their concerns, experience, and many other things. So that's my experience. That's what I have done, and I want to show you more pictures. You can't see, but the picture, right? The same picture, right?
Yeah.
Very nice picture. Yeah. Thank you, Hassan. That's really.
I'm sorry.
Yeah, no, that's wonderful, and I think you're again. How do we make the knowns as the unknowns known? And so having videos and pictures and sort of stories and capturing what people's lives is. Are those pictures by the children?
Yeah, this was a child with autism who was an artist. Mm-hmm. So we presented his paintings on the walls of our I don't know what you call it, the place we used to meet. So
yeah.
that's what.
Mm-hmm. Yeah. Wow.
Mm-hmm. Those are 3 autism children that this guy has raised. His wife has died, and he raised them by his own. Mm-hmm. Yeah, here we were blue because the blue is the color of autism. It makes them comfortable and relaxed. So that's why we were.
Yeah.
Wow.
Those are two cancer patients, the kid and the one who's wearing the oldest one, the one who's wearing black. Those have cancer.
Mm-hmm.
He's a medical student, and she is, I think 6 years old.
Mm-hmm. Mm-hmm. Yeah.
Those are the kids from the Down syndrome nonprofit organization. I wasn't there. I'm gonna show you another one because this is. This was a patient with depression, talked about her experience on one of the events. This kid, her name is Wasantu. That's why.
Wow.
This is the doctor. He's a pediatrician. He is a cardiologist too.
Mm-hmm.
And most importantly, this one, we put 100% of the profits for this gas stations to help people who have cancer.
Mm.
Wow.
Yeah.
Yeah. No, that's
That
awesome. Yeah. Being creative with finances and sort of getting resources going is really important. So I can. There are some people with Down syndrome come under the category intellectual. The population intellectual disability. So, and I have done some work with some disabled groups here. So I'd be able to give you some sort of links to that, because unfortunately people with Down syndrome are particularly susceptible to Alzheimer's and dementia. It's to do with the vitamin D. So there are a number of projects which are looking at how parents and caregivers can be helped to sort of work together and get people's lived experiences sort of captured. So thank you so much. That's a really nice example of working with people, helping people, supporting people in community, and sort of also trying to think a little bit now how you use your experience and bring it to the States, how we can connect you with the organisations here, which will enable you to carry on doing that work. So thank you very much. I really appreciate that very much.
Thank you for letting me presenting it, and Ms. Fatima too. Thank you.
Yeah.
No, thanks, Susan. Beautiful presentation.
Yeah. So okay. So this is so cool. So I'm beginning to get a sense of where all your passions are, and your sort of where you love, possibly potentially you're identifying issues where you'd like to get more involved, or advocacies, or connections with the connections that you might be looking to make. So we're talking, yes, going back to but obviously we do need processes and planning. So we're in the pre-engagement community phase, but a lot of the work we do here will also be about partnership and infrastructure development, interestingly enough. So the two things I think are linked. Again, things are never sort of separated out as neatly as the diagrams suggest. So if we could have the next slide. And so your journey is very much, I think, to assess the information that's out there, to translate that. And this is where you are doing some asset mapping. You're getting a sense of the lay of the land, the literature, and the what's happening in the American system, and what the American system thinks are health disparities, and how it identifies health conditions and health behaviours. And then you have to decide to partner or not to partner with the mosques, and Worry Free is going to help you identify mosques that might be interested, and then you're going to go in and sort of talk to those leaders about MPART, eMarch, PCORI, and then potentially as part of that discussion you'll be working with those leaders to identify your audiences. Now we already know that that's actually very problematic, in the sense that the demographics don't identify Muslim Americans. The demographics are not helpful to us, in terms of they talk about vulnerable populations. They talk about so we already know that's a little bit difficult in terms of relating a population to a research agenda, but we also know that there are obviously community-based participatory research and PCORI engagement research, like the one we're doing, makes it perfectly possible for you to identify the audiences who you'd like to meet and reach out to. And we know it's going to be people who are interested in learning more about health. So yes, so then we've got the messages, we've got the message to the imams, and then we've got communicating resources to the public if the imams allow us to do that, and possibly doing asset mapping either within the community or there are other ways of doing asset mapping, for example, a windshield audit, which I was just talking to Fatima about, which is basically an audit to evaluate community resources for healthful life behaviours. So there are many different ways to deliver what we said in this work plan, and to do that asset mapping. But the talking to people bit is not always easy to deliver. So I think we just need to think through all the different methodologies and tools, so that when you're talking to the leaders of the community, you can explain what some of the options might be. So if you go to the next slide. Okay, so as you begin, step one is you're going to meet your mosque leader or a contact. You're going to introduce yourself, ask and answer the questions, who and what is this partnership for? Why the mosque community and worry-free? What's the story so far? So in telling the story so far, you need to talk about what eMarch is, what MPART is, what PCORI is, and maybe even suggest what are the top concerns for Muslim Americans. And I can share those with you in a moment. Then step two, you'll be working with the leaders to make sure a research-focused partnership is a good fit, and that you and the leader have a shared understanding of the ask, how many times you'll be going to the mosque, and the goal. So I think as a group, we need to practice the ask, and also we need to think about the goal of the exercise, of why are we engaging. And we will do that. There'll be some exercises to do that to help you do that. I think it's also important to find out whether the leader wants regular updates, and from whom, because that might be from Worry-Free, or it might be from yourself, or whether they're happy to hand you over to other mosque leaders or health educators to work with. And then that sort of leads to step three, which is that you might need to work to identify stakeholders or audiences to share the issues with. And this is where it comes back to, are you going to focus on populations needing access to care, Muslim Americans with a particular health condition, or other? So these are all very important. Think about your audience, really think about who that is, think about those patients that you want to engage. And you'll also need to explain asset mapping and other potential activities, and just come up with a plan for when that's happening. And I think Fatima's going to share a timetable with us at the end of today's session, just to help you begin to put the pieces together, the pieces of the jigsaw together, and when things might take place. And then I can't quite see the bottom one. Is it 4? Record all the dates of your outreach activity. Yes, we need you to record all the dates of your activity and your concerns shared and issues raised and contacts made, because as Fatima shared yesterday, we're going to try and count those. We're going to do an assessment of the number of times that you managed to connect, and what those connections are about. So if you have the next slide. So here are the top health concerns for American Muslims which were identified by the eMarch project, which is the project led by Dr. Padella. I think Fatima was involved in that as well. And so what's interesting here is these are the issues that came out of that project. So as we go through these, can you think, and I know this is instinct, but is there a health concern that you think is most prevalent in your community? Does this list of top 10 things correspond with what you're feeling in the communities that you're in? So I don't think they're in order, but the top health concerns which were identified were mental health, lack of a culturally appropriate or religiously sensitive healthcare, underutilization of preventive healthcare, reproduction and sexual health, substance abuse, lack of Islamic bioethics knowledge, interpersonal trauma, which is domestic violence, sexual violence, so those types of things, Islamophobia-related health impacts, racism, and sort of those factors which, as you will have seen from the Robert Wood Johnson, don't always come up in the models, elder care, and immigration health, which we have touched on a little bit, because obviously immigrants are one population that the databases do have a look at. So is your does that correspond with your sense of could you is there one there that stands out as being something that is a top health concern? I mean, I think teen health was mentioned, wasn't it? Has been mentioned. So that would link to mental health, and it's interesting that you mentioned that there was a mosque had set up a teen health sort of support group. Substance abuse, is that something that is being addressed by mosques, or is potentially a problem that people might need access to services to address, or support groups, or confidential support groups? No? Okay. So those were identified by the eMarch project.
Substance abuse is an issue, but it is not being addressed by the mosques, and that is one of the growing concerns among Muslim community leaders here. We have talked about it among ourselves. We know that it exists. We actually encounter. We refer them to the appropriate places. However, there is not a single program, standardized programs that's being accepted by mosques and saying that, yes, this is what we are going to adopt, and this is what we would provide the education for or on. So I think that's definitely a need out there.
Okay, so that's a good question. So does Worry-Free offer services for any of those things, Fatima?
We don't offer services. We simply direct them into the appropriate places. That's what we can do at this point because of lack of resources. Mm-hmm. But definitely, that is one thing that we have that as an agenda item, but on the back burner right now, honestly, because of lack of resources. That's mainly it.
Okay, and what about the other issues? Would you be able?
Yeah, so we do immigrant health. We do take care of that to a certain extent. Elder care, we have a partner program with some people. Underutilization of preventative healthcare, we actually do partner with Compassionate Care Network. In fact, I used to run their program, and Worry-Free Community came out of that program.
Oh, okay, right. Yeah, wow, yeah. Okay, that's cool. That's really cool.
Since they were focusing on preventive health, I said, let me focus on the access to care. So that's where we came. And lack of culturally appropriate and religious sensitive care. We do provide. We actually provide training programs with other partner organizations on specific topic. So to some extent, I mean, we do cater to some of these, but not all of them. Right. And lack of Islamic bioethics knowledge. I mean, Dr. Padilla has his thumb on the pulse, so we leave that up to him.
Right. So yeah, so that there, I thought it was interesting to share those health concerns which should come out of that earlier project. Yeah, and just to get a sense of, yes, I suppose so.
I'll highlight one of the things, reproductive and sexual health. We didn't realize how big of an issue that is till the eMarch project. That really was a jaw dropper for us. We did not expect that to be one of the top 3 problems in our community, actually. So and there are some resources. There's actually one of the eMarch member, the cohort member, just like, we have a cohort for the younger people. We had the cohort for, these were the students that were coming out of the PhD programs, or running their own organizations after in their professional life. So there are 2 organizations, actually, FYI, that's in Michigan, and Mona Elgohel. She has an organization that she works with. Both of those organizations actually help out with this particular priority. But she's in Pittsburgh now. Yeah, so there are but very few here and there in the nation. So in fact, I mean, when things come to that extent, we can always refer a client to those folks that, because it's a nonprofit, they should be able to at least do something virtually.
Okay. So there's yeah, that's great. That's really good. So if these things come up when in discussion, if these are sort of, mosque leaders say, oh yes, for me it's there's, yeah, I'd like to know more about access to mental health. It would be we as a group, we would be able to sort of pool resources, and it may be national as well as local. Okay. All right. Good. Okay. So yeah, and then these are sample outreach logs. Now I just put these ones. These are actually all from Pastors for PCOR, but I will work with Fatima too, and we will make sure that we get the documentation sort of with the worry-free logos on. But the basic idea is that you're talking about the name of the mosque, the person you're dealing with, the date of your contact, and the nature of the contact, and then any comments on the comment. For example, sort of I spoke to the mosque leader, mentioned need for access to mental health. That would be something you put in the comment, and then you can share back to Fatima. This example here, and we'll need to talk about this more, is if you get to the point where you are beginning to describe an intervention that you'd like, that you have a good conversation with the mosque leader or the health community person, and that they clearly identify an issue that they would like a group, a population, and a sort of intervention that they feel is really needed. This is where you can begin to sort of plot that out a little bit more. So it's more of a sort of what type of intervention do you want? Why? What would the outcomes be? So you can begin to you can use a form like that to sort of start jotting down ideas. It doesn't have to be for research. It could be just for advocacy. We need more access to care for, or more support for Muslim caregivers of children with Down syndrome, for example, like Wassam has presented. So, or more information for Muslim families with children with disabilities. So there'll be different ways. This is just a way to log the experience, but we'll work that out for you, and we'll give you like an information sheet of how to use the record sheet, because I know Fatima has got the online databases as well, and so we need to make sure that whatever we capture can be easily put into those as well. Okay, so if you have the next slide. So what are the key factors which will support that initial outreach, that support effective relationships? So it's not just the initial outreach, but it's also sustaining the relationships, which is often quite difficult. So we talked about the guiding principles, which is being informed, having respect for lived experience, and working together. So those are still must be in your mind as your guiding principles. But the other thing which is really important is that, and I think this goes back to this idea of teaching one to reach many. So the more you get with that first contact with the imam, the more you can explain clearly why research might be of benefit to a mosque community. That always has a knock-on effect, and it's a sort of ripple effect. And then having a representative voice, which is yourself, but it could also be finding a representative voice in the mosque who, and then just making sure everything's really clear and it's constructive collaboration. And I think having a protocol, I've kept this in here because these were some interview cards that we had for a project. And so just making sure that you have a protocol. You know, we talked through the difference between a chat, a conversation, and a semi-structured sort of talk. I think it will be important for us as a group to all have a general sense of the questions that we're asking when we go and reach out to people, because then we can feed back our experiences. So if you have the next slide. So be informed, getting to know the community area. This is what I wanted to show you this. So there's two key sources. There's the Chicago Area Atlas, the Health Atlas, or you can select your county in the Illinois Gov.map. So what I would like you to do is review, I'm going to go look through because I want you to be able to review the health data about your community and then identify health disparity, a known health disparity around access to care or a priority health condition relevant to your community. It was nice to see so many mosques, actually. I didn't realise they were quite so, across Chicago, there's quite a number there. And then you've got the Downtown Islamic Center as well. So it does come up in Google. All right, so I will. We'll come back and I'll talk you through, and then we'll come back and we'll try entering some. We'll open that link, and it should be live, and we'll try entering some other zip codes. But let me talk you through what you can see when you open that. All right, so if you have the next 3 slides. So the next slide is so when you type your zip code into the Chicago Area Atlas, for example, 60653, you get a list, and it shows you here. It tells you that it tells you the community area, and it tells you that there's Douglas. It suggests there are corresponding community areas, which means that we could, if we want, go beyond 60653 and sort of actually look at the community area, which would include these different things. And that really matters in terms of if you feel that the community area is actually more important than the zip code, and people identify as being from Oakland or Kenwood or Douglas, that does matter. Underneath there are all these area resources, and it lists all the area hospitals. And so if you look at if you click on area resources, you actually get and I'll show you what you see, but it's basically a list of libraries, places to go for healthcare. There's a whole series, a long list of them. And then what you can also do is that this is just one of several indicators. So access to care. And so it basically number crunches for you. And this tells you that in this particular 60653, 934 people out of in every 10,000 people had avoidable emergency department visits, compared with 542 for every 10,000 of the population in Chicago. So that shows you that there's a lot of people in this zip code having avoidable emergency department visits. And as you can see, dental care emergencies, again, are much higher than the Chicago data. It's not quite, that's high. So this is where you see that there are particular issues. So the maps will tell you which issues there are. In terms of health disparities between areas, between community areas. So if we go to the next slide, this, for example, is what comes up when you click in 60653, and you can see here the Muslim community there is is actually marked on there, along with these other ones. So community services, these are all in this particular area. So these are the types of resources that you can see when you go to zip code level. Okay, so all right. So if we go back to this slide, can we, Fatima, can you click on that link and see whether it works? It should do. Yeah, excellent. Okay, so does somebody want to share a community area or a zip code that they're interested in?
You can do 60139.
60139. Okay.
I need to put some kind of an indicator, right?
Not necessarily. You shouldn't need to. It should just take it. It should take it to you. It says no results.
This or this or this. Okay, let me do one more time.
It should be. Okay, or view. Yes, it's maybe that way around. We could do that. So, yes, which community area do we want to go to? So, where is 60139?
Can we try Rogers Park?
Okay.
Oh, you know what? Because this is Chicago Health Atlas. We are not within Chicago.
No, sorry. I'll have to do, yes.
Yeah, let's do Rogers Park.
That's yeah, the Illinois Department of, yes, well, I'll show you that one in a minute. Yeah. Mm-hmm. Okay, so here's Rogers Park, right? And so it'll give you, and again, we've been talking a little bit about income and how that is often something which is a factor for health disparities. So it gives you that, and it gives you the gender, and then it breaks it down by race and ethnicity. But as you can see, we have this problem with race and ethnicity, as it were, because it's not necessarily enough demographic categories for that to be meaningful. Okay, so we keep going down there. I think that's So the community data area. Right, so this is where so the community data area. So here you see clinical care, and that one you've got social economic factors and you've got demography. So if you just click on the little here we go. So community safety. So there are some social economic factors here. So there's community safety, and then there are, and so again you can compare Rogers Park with Chicago, and you'll be able to see. So income diversity is, roughly equivalent. College graduation is a little bit higher. I'm not surprised by that because a lot of students live in Rogers Park. And sort of, so you can see some of these. Here we go. Single house, foreign born, limited English proficiency, so sense of community belonging, unemployment. So there are all these categories where you'll be able to get a sense of your community area and the issues which are going on in that. So if we have a look at, if you go up to access to care, let's see how that one is. We've got poverty rates, SNAP there as well. Education levels. Grocery, SNAP. There we go. So there we are. So food SNAP. So you've got a sense there of. So the only thing is that this is actually a good one. Rogers Park is a good one. It's got quite good data here. It's got quite sort of good coverage. It's not all areas are actually as well served. So if you click on disparities, let's see what it tells us there. There's one at the top. Just the top. So you see summary just across from there.
Oh,
yeah. Mm-hmm. There we go. So foods. There you got a sense of the disparities there. But what's the problem with that graph? Is that helpful to you at all? It's
so out of total. I mean, is that representative of the proportion? Is it proportionally representing the total population? We don't know that.
You've got Chicago at that end. So you've got 18.9 is Chicago. So 18.9%. Yeah. Is,
I see. It's actually giving you that. Okay, I see on the side of the screen. Yeah.
Yeah.
But that's the average, though.
Yes, it is the average. Yeah.
The question is: this showing the percentage by ethnicity that are on food stamps or that are not on?
Can you say? I didn't hear that. Can you say that again?
Sorry, is this showing the percentage of like the ethnicities that are on food stamps or not on food stamps?
On food stamps, the ones in receipt of food stamps. So it's basically saying that 50 of those surveyed. It's the limitation is of those on of those surveyed and on food stamps, or to the government's knowledge. In Rogers Park, 60% of African Americans have food stamps. 4% of Asians, 25% Hispanic or Latino, and 12% roughly about non-Hispanic and white. Mm-hmm. Yeah.
You know, one of the things, if you look at the total demographics or summary, it's actually telling you that how many people are there with respect to different races. Now, that is, I know Rogers Park is actually a heavy immigrant population as well. Now, food stamps are primarily received by those people who are citizens. So even though the immigrants who live in that area, and there are about 25% of them, total population. So and very often the first 5 years while they are here, in fact, first 10 years, they are struggling to make the ends meet and remain well below the poverty line. So, but they cannot receive food stamps because they are not citizens.
Yeah.
So you exclude those people. So African Americans, it does show the higher population. Latino, Hispanic does show a higher population because those people probably have been there for a longer time and are eligible for citizenship and therefore eligible for food stamps. So even though the new immigrants, they may not be eligible, but that doesn't mean that the need doesn't exist.
That's right. That's exactly right. So that's the issue. Yes, that's right. So it's the unknown, isn't it? You know that, but the government data is not saying anything about those people, and so this is why you're so important within the community. It's really, really important to begin to get a sense, I think, of how. What role is food stamps playing within an immigrant community? Yes, is it about not being able to access it because one isn't a citizen, or is it? Yes, yeah, it's the gap, isn't it? It's the evidence gap. Is that this is the data that decisions are made on, but there's
somebody needs to compare this with the food pantries data.
Yeah, that's right.
That's what I'm curious about, because there's only one food pantry and like one community center that enrolls people in SNAP in Rogers Park, and it's primarily in a Black community. So that's where I'm like seeing this, and I'm like, oh, makes sense. But the question in the chat, I really want to know that answer too.
So, sorry, what was the question?
I don't have access to the chat box on my phone.
Oh, there's a question in the chat.
Oh, sorry. Okay. Are Muslims part of the 11%, the non-Hispanic group? That's a great question. And I think we should ask. We should ask the. I will ask the epidemiologists at the city. I know. I can contact them and we'll ask that. We want to know where the Muslim Americans appear in these graphs. Yeah. Okay. Because are they in the Black column, African American or Black, or are they in the Asian, or are they in the non-Hispanic? I don't know. I don't know the answer to that question. So I will ask. Okay. All right. So, do you want to try another zip code, or are you getting the hang of this? Do you think are there questions about how you can sort of navigate this, or Shall we look at another zip code and see what might be coming up? Or it's sorry, community area. Mm-hmm.
What is the site for the Illinois, for example, where we could look up Glendian Heights Other?
Yeah, so if you go to the go back to the slides and click on that link, I'll be able to show you that one.
Oh, this one?
Yeah, that's right. So let's see what that one. I don't know this one as well, so let's see what we can do. Okay, so it's a public health community map, and so you can if you click on try clicking on one of those squares. Yeah, the one that relates to closest to you, maybe closest to you is where is it?
This is so funny.
Yeah.
The map is flipped over like a mirror image, and I'm having such a hard time.
No, you're right over by Iowa that way. Yes.
Yeah. And it's over here, so I know exactly.
Yes. Yes.
Okay.
There you go. That's right. Try that one. Yeah. Okay. Let's see what happens. Okay. Here we go. So, yeah.
Oh, look at that! I like that. Yes,
that's right. Okay. So you've got age breakdown. You've got income. Yeah, you can. So, and again, you can. There are asthma visits, similar sort of thing. So similar sort of. There are categories that you can explore. Looking for that. And again, you see, you've got the same problem. You've got the ethnicity. There's no way. There really isn't. So there's measures. There's emergency department asthma visit rates, for example. If you go up to select a measure, I think you'll be able to see. It'll be a drop-down one. That's right. And if you select a category, I think you should be able to see the categories there as well. That one, yeah. There we go. So you've got wellness. Okay, let's have a look at wellness. Let's see what it comes.
My favorite topic.
Okay, and then you've got, oh good lord. Okay, so now you've got adults, smokers. Okay. Yeah.
Well, that's the only measure we got in wellness.
Oh no, that's no good. Okay.
Oh my God! Seriously?
Exactly.
That's how much you know about wellness.
Yes.
Yeah. Okay, let's see.
There are some other behavioural health ones down there as well. So there's primary
behavioural health.
Yeah, substance.
Oh, substance-related disorders.
Yeah, try that one. Yes. Okay.
You.
Yeah, and again, we've got white, black, Hispanic. So yeah.
Substance-related disorders. Okay, so we have. So if we go to any other race, we actually pair mix. Oh, we got pair mix and education. So what kind of a pair mix that is self-pay or private insurance or Medicaid is 30% and 34% is private. This is self-pay, which is 11%, and Medicare is 20%. So Medicare is 20%, and you look at it, it's over 65 is age breakdown is 10. So basically, Medicare folks have a positive disparity here.
Yeah. That's right. Yeah.
It's interesting. Yeah.
Okay, so that's fine. Just yes. All right. So I wanted to introduce you to the data that is there about health disparities, and we're going to have to. But there's obviously a lot of gaps. Okay. So if you go back to the slide, and I would have a look. So once you've been out, have a look at your community areas where you are in all your counties. And have a play with those. See what the data is telling you. Okay, so if we keep going down, we scroll down. Okay. All right, and next slide. Yes, so this is an example of when you go into a zip code area, you can actually go right the way through to a very detailed one. And the little that I'm not sure I managed to capture the legend, which is the sort of legend at the top. But the little beds are where they provide care, and so these are examples of community-based centres where they're providing care. And you can then see where those
with
are.
Care, do you mean with care? Do you mean primary care or emergency care or urgent care?
It just says care on the.
Okay.
So yeah, again, you see, this is what we don't know. We don't know, do we? So how we're going to have to investigate those assets and see what they mean. Yes.
Okay.
That's right, which is why I'd like the idea of a windscreen thing. But that's right. So how are we going to find out about those assets? It's word of mouth. There's this database. But yes, how are we going to find out whether they're useful, and also whether they're not just whether they're useful, but whether they're culturally appropriate? So yeah, whether you'd want to use them. So that's sometimes word of mouth. So yeah, this is our task, isn't it, to sort of work out what the resources are in a particular area and community area or by zip code, and then sort of work out which ones you feel comfortable recommending. And which ones you need to know about around a mosque, and you could possibly encourage connections with. Okay.
Dr. Johnson, so we should actually select some kind of topics or actually related to this particular slide. I think what we should do is have our resources reflect these concerns or these kinds of providers.
Okay. Mm-hmm.
In addition to definitely the primary care, specialty care, and therapies, and access to care, and maybe perhaps shelter, food pantry.
Yeah.
Those are some of the very basics. But in addition to that, we can also map out some whatever we can out of this, because I know not every nonprofit social services provides interpersonal trauma counseling or have those kind of services. So I think this is the list that was identified by the eMarch project, and eMpart. I almost think that it's eMpart's fiduciary responsibility.
Yes,
to map out these resources on the asset map.
That's why I introduced them, because that is the question. Yes, is it do you just want to focus on access to care, which, as you can see when you look at the databases, you could just focus on access to care, but I think it makes sense to create resources for each of these topics.
No, that's the biggest gap that worry-free community also has, and fortunately we actually do become assets to other nonprofits where when they cannot do or they cannot provide those kind of services, they send it to us, and likewise we send it to them. However, there are other gaps that are there. For example, we do quite a bit with the free clinics, and the free clinics, they have a specialty care, primary care, and they say that, you know what, we have this patient out here who really needs access to care. Can you help this patient out and put them into the right, direct them into the right resource? Because sometimes there are people that may not have the legal resident and have a long-lasting or care that they needed. So county care program with DuPage County or Cook County can actually help them better than any free clinic. Yeah. So we direct them to that, and we enroll them in those programs. So likewise, we don't have people, or we need to know where are the resources for the interpersonal trauma or elder care or reproductive and sexual health kind of those are all those we get questions about them all the time.
Okay, so that's great, and if everybody is happy, I would think that's a good idea. You've got to start somewhere, so resources for that is a good idea. Okay. So, if we keep going, okay. So yes, so thinking about your audience. So do we believe that health research information we want to share is actionable? Yes, these have come from. That's why it's so valuable, because it's come from a previous project, a previous PCORI project. Is it?
Sorry. Let me mute myself.
That's okay. That's it. Yeah. So we're already thinking, yes, it is relevant, but we're also seeing the weaknesses of the big picture data. So it would be, yeah. So we see the need for creating resources to things that have been identified by mosques and mosque leaders, and if it is relevant, then we now want to know whether or not we can sort of we want to identify resources which are relevant, beneficial, and possibly actionable to populations experiencing health inequalities. So okay, so we'll yeah, I think we have to think about our audience. Okay, can we next slide? I do think the other important thing I would say is it is be prepared to not engage, because it's not a task you must do this willy-nilly. If when you meet the leaders it's not a good idea, it doesn't seem to be a good idea, that don't forge ahead. So I do want to say that it's like when you sort of ask people to be involved in trials, it's okay for them to say no. This is called, in research speak, it's called voluntariness. So, and because people can be very pressured to engage. They can, for example, if a teacher asks a parent, to get involved in a school project, there's a lot of pressure there to be involved. So I think it's okay for everybody to agree that it's not a good idea. So, we've got a problem, which is health inequities. We've got an action that we'd like to do together. And the question is whether or not a partnership is the right approach. That is the question to address a health inequity. And if it's and if the information being shared is relevant to the public, by which I mean the mosque community. So if no, that's fine. But if yes, it is the right idea, you then need to really think about identifying the audience, as we're talking about, and asking the audience stroke patients stroke community members, where do you get your yes, it could be about asking them where they get their health information from, or it could be about asset mapping. But I just wanted to give you this diagram to sort of say there's a decision-making process to go through as well. Okay, so next slide. So always be honest and transparent about the ask. So make it clear where the money's coming from for the funding for the project, who's making the decisions, who's at the table. The fact here that that your community, you're a mixed group of stakeholders, community members, professionals, but very much sort of mosque focused is very important. Okay, so always be honest and transparent about the ask, and we will make sure that you are clear about the ask as well. So keep going. Here's the next slide. And try and understand the benefits of getting on the same page, and be able to talk about those. This was a project I did with home care aides, and they shared what they felt benefit was of getting on the same page. And by getting on the same page, that means everybody, for every stakeholder, from every perspective, understanding why we're all working together. And they came up with statements like, everyone in an organization has a role in research and plays a critical role. One thing I learned about myself was my ability to complete the project. I couldn't believe I'd gotten my client to complete this entire project. So, but the nice thing is, that's what we want to get. We want to make sure that everybody feels comfortable, they're on the same page, and that they're learning from what they're doing and working with each other. Okay, next slide. So also we've talked about listening and the importance of that. So deploy the shared behaviours that we've talked about during the training. So listening, agreeing common ground, sharing things that people know, everyone knows, but might be problematic. Think about what evidence you want to collect for whom and how you're going to sort of communicate the steps, and then listen and connect and strategize. Okay, so next, just to deploy the MPART shared behaviours and know the worry-free current community work, projects and programs, because I'm sure people will ask you about that. So if you have some information about the worry-free organisation and how it actually works to connect with all the activities it does, and the outcomes of change that it wants to achieve. That is that, but in a simple way. That is good. Do you want to say something more, Fatima? I think, is there another?
Father, please unmute yourself.
Sorry about that. So the website actually does provide some basic or the focus areas where we are doing the EM part. There is Worry-Free Health, where the Access to Care project. The Access to Care project has gotten very, it's gotten actually many layers to it, and that's actually now is taking a lot of our time, even though it looks like, oh, all there is to it is that person really needs a healthcare coverage, and just make sure that they have a healthcare coverage. But there's so much education that goes with that, and there are the network information, and now we are directing the physicians and helping physicians where they actually lose the network where their patients are. So somehow they don't get registered back into the appropriate network where their patients belong to. So now we have started to help them. So even though it's Access to Care, but Access to Care has so many layers, it's unbelievable. And then we also have the Be Well Clinic, where Nabil is a big part of it, and Bilal is a big part of it, alhamdulillah. So that is a wellness clinic, and we are just embarking with this idea to collect wellness data. And there are a couple nurses out there that would be providing the health education, and they are very much interested in all of these topics with the the trauma and the abuse, the substance abuse, the education and chronic care management itself. So we are partnering with several other organizations out there. And in fact, all of the rest of the organizations, I'm looking at it, that they can be assets, and we are assets to them. All of these programs are assets to them, and they're all assets to us. Each one of us is actually an asset to each other, where we support the need, where we can all support the needs of our community by sharing the objectives. And then since we are putting all of the information into the databases, we should all be thinking about how to communicate the needs, and perhaps maybe we can have a data management or database kind of collection and outcomes measures, and have smaller groups for that, for the data management, where we can collect these data across the programs and across the projects and feed it into each other, because all of this data feeds back into the community needs. So every single data point actually supports the community needs assessment. So I'm very excited with all of this, and hopefully we can work with that. So once the project is over, this particular project, as it gets over, it will return back to its initial phase, not as a project, but as a program. But within the program, and it can continue going on and on, where you train certain number of people to take care of the community needs, and then those people move on and you train the next batch. While you are doing this, every batch that is trained and collects the data, what are you doing? You're doing two main things. You're actually creating capacity in the people who are getting trained, and therefore you are creating capacity in the community. On the other hand, you are collecting the data as they serve the community. So you're building capacity while you are supporting the community needs assessment. So it's a beautiful marriage here, where we can, and again, with that is what the impact is all about, and that's where the whole change behavior theory comes in.
Thank you very much. So yes, so it is important to know our shared agenda. So I wanted to give you, and this is where Fatima began right at the beginning. We're talking about the vision and the mission, and so the mission it's very important for us all to have a shared agenda. Now, I've given you some examples of other shared agendas. That's why I wanted to just do that. But so we do need to agree we're a partnership of working together too is the sort of the format that we need to the mantra that we need to think about. So can we go to the next slide?
Sure.
Okay, so here this is just a sort of I'd like you to think about sort of practicing an elevator speech. So I'd like you to think about completing this so that because we've gone through over a lot of things, and I think sometimes we just need to think about, what is this project about and what are we trying to do? And I've made some suggestions here, but these are just placeholders. I think we should change them if we want to. So the idea is to sort of complete the hi. My name is, and I'm a member of the MPART Equipping Muslims with PCORI-based action-orientated research tools partnership led by Worry Free organisation. You know how Muslim communities remain on the margins of community health interventions and health systems lack the knowledge. And health systems lack the knowledge to effectively engage mosque communities. Well, what we're going to do is partner with mosque leaders and mosque community health and wellbeing partners so that communities know when, where, and how to access culturally appropriate care and how to engage in patient-centered research. So, and then, you know me, I like metaphors. So we're kind of like and then that helps you, I think, to imagine your role, if you like that sort of that way of thinking. So I'd really like everybody to have a go at sort of crafting that so that you're comfortable with it, so that you can get up and say what you're part of, what we're trying to address, what we're trying to do, and how we're going to do that. So I know it's 6:25, so maybe I can ask people to take that away, think about it. Don't be too complicated, and try. We're going to practice. I think it would be a good idea to practice. If some people will be happy when we meet again on Saturday, just to start the session by sharing, what you've come up with, and it should be very, very simple. That will be our icebreaker for Saturday. So I wanted to give you a couple of examples of how PCORI is addressing disparities in health and healthcare. So it does, as you know from yesterday, it does address disparities. It does do projects which address disparities. And it has actually funded 97 research studies and projects to help patients at risk for disparities. So there is this definition out there of what health disparities are in health and healthcare. And so an example I would share is, because I think smoking was mentioned earlier on, was the question that was asked by a researcher was, are there evidence-based smoking cessation treatments that take into account personal characteristics, age, gender, and cultural background? And so that if you'd like to have a look at that project, you can link through that. And then I also wanted to share in the next slide another PCORI project, which is related to teen mental health. So this is where you see, because these are assets we might be useful to add as well to our picture, is what researchers are doing at the moment. Now, this is actually a project at UIC led by Benjamin van Voorhees at the UIC Medical Hospital, and they are comparing two programs. They're prevention programs for teenagers, and I picked this one out because this is they're actually sort of it's live. It's for teen mental health, and that was something that got mentioned earlier on. It's mental health, which is one of those 10 sort of one of those issues and concerns, and it's also local. The other thing is it's actually drawing on inner city and suburban communities, African American, Latino, and Arab and white teenagers, as well as teens who identify as LGBTQ. So I thought that might be actually quite an interesting one for you to sort of know about as well. And their website is great. They use comics to talk to teens about mental health, and they use it's a cool website. It has skateboards and things. So, to join, you're invited to click on a skateboard and fill in your details. So that might be something that might be of interest and have in your back pocket. Okay, so there's next. I think that's yeah. So if there are any questions, we'll go return to asset mapping on Saturday.
Yeah. Can I just share the link of the video on the chat so you can watch it? Yeah, you can watch it later on. That's okay. But this is the link. It's translated.
Oh, thank you.
And Waslam, you could also share that on the social engine too.
Okay, how can I do that?
Okay, on the social engine, if you have a login on the social engine, My Health, My Responsibility, you can also do it here as well, but because that's where people could have access to it all the time. But you can also always do it here as well. We can send it to the folks in the email, and we can also have it on the social engine. So anybody can go in from anywhere, and they don't have to log into their emails or get this, and then they would have it on the website then.
Okay, I will do that. Okay.
I'll coach you through that tomorrow, inshallah.
Inshallah, okay. That would be good. Okay.
Okay.
I just sent that link.
Perfect. Thank you.
Okay. Thank you.
So I just want to mention this, that that we're going through the training in September, October. We're actually a month late in this particular training because of COVID, but in the October we are now being assigned to the mosque. So more than likely Saturday we will have our final. In the meantime, I'll be talking to each one of you and making sure that you're comfortable with the mosque, or you have a mosque in mind that you would like to serve. By all means, please contact me. And then so from November, December, January, and February, up until February 2021, next year, we would be doing the outreach in the mosque communities. So some of us actually really like to go in and serve the mosque. However, because of COVID, we are not able to. So instead of showing ourselves, we will actually have flyers in the mosque that would direct people to the websites. So the My Health, My Responsibility, once we are at a comfortable stage with taking calls and answering questions, possibly towards the end of this month, we will also have the kickoff meeting most likely. It's tentatively set up for November 1st, I believe. That's the Sunday. And then once we are after that meeting, we would be taking calls and chatting with the consumer that's outside our organization, and you can have your dedicated hours once a week or however you want it on the online presence, and you can that's where you would hone your skills for outreaching. And so we will, there are tools going to be there. There's in the last couple sessions we will have the practice sessions on the social engine, so you would be comfortable with doing that. And in the meantime, as you are going around and making contacts and getting to know people and building a community, you're actually thinking about having a town hall in March. So every mosque, we particular mosques that are listed as stakeholders, every mosque will have its own town hall. And the purpose of the town hall is basically to share this idea and advertise or share this idea of having the asset maps available to the other rest of the communities. And these stakeholders, as you see, So what a town hall will do is it will bring all the stakeholders together. You saw many slides with the stakeholders listed. There are hospital systems, payers. These can be government peoples. They can be healthcare providers. They can be patient caregivers. They can be patients themselves. They can be imams. They can be board members of the mosque. They can be other community-based organizations in the mosque, and the assets that we have mapped. All of these people are actually stakeholders in EM Park project because they're all serving the same patient community. Okay, so all of these people can actually meet and greet with each other at the town hall, and that would be a virtual town hall. So think about having a virtual conference in a room where you're having all of the attendees and you are presenting maybe a 20-minute or a half-hour presentation. So these town halls would no more be 2 hours, but there would be a small presentation, and you get to talk. You get to talk if it's your town hall, or you get to watch if it's your peer town hall. So the community members can ask questions to you with you, and these are the people who you have known before. So it's more like a get together, meet and greet kind of a session. Now in April we don't have anything, and in June, but in May we are actually preparing for the conference. So we had a Picori conference, Muslim Picori conference, in 2019, in October last year. So we don't have any Picori conference this year, but this particular project actually has funding available for us to have the Picori conference. And it is one of the project deliverable as well in 2021. So next year in June, there is a conference where you would be presenting your highlights and whatever your achievements are from this project, your thoughts and how it has progressed you in your profession. You would be sharing that with your peers, with the people out there at the conference, and that will be held in June. So in May, we are primarily preparing for about 7 weeks we have kept for the conference preparation. But to start thinking in how you would be presenting, what you want to present. And that's a national conference. You would also meet people from the previous eMarch project that will be there, inshallah. And you would also see people who would be joining us in the next project, inshallah. So start thinking about the next project that you would like to be a part of. And so, another thing that we would be doing at the end of this project is we would be hiring about 3 to 5 community health workers that can serve us in the worry-free community and serve the community with all of the different asset maps and the outreach, because we have now created a need for the outreach in the community. We can't just pull ourselves off the community. So you do for 4 months, you are providing a benefit to the community. And now since the project has ended, we just can't say, oh, we don't have any funding, and we cannot sit there like that. We have to make sure that that gap for the community doesn't happen. We need to, that's what we have committed to. So we will be transitioning the project into a program. So therefore, we will be hiring those community health workers that would then be supporting the outreach that you would have started actually. So see how a project is converting into a program, and that's what inshallah we plan on doing. May Allah be with us and provide us with all the deliverables. Help us in that. This is just the actual item, action items. Dissemination, implementation, and evaluation are the 3 components for the PICORIs. This is PICORI terminology, by the way. So dissemination, implementation, and evaluation, it comes from their language, just like you have plan, conduct, and disseminate. So if you break down the last part of dissemination, it comes out to dissemination, implementation, and evaluation. So these are some of the planned activities that we would be doing. Okay. Sorry, I just took a little bit more time than I intended. Questions? we would be meeting again tomorrow at 5 o'clock. Any questions, guys? Thank you very much for being a part of this. I'm very excited to have all of you here. So if there are no questions, then we will see each other tomorrow at 5. Thank you.